screen?
Yes.
All right, so I kind of went through this last night just to make sure that everything was working. And some of the images that I put in here were a little laggy. So just let me know if any of that, if you're having issues on the visual side. Um, but yeah, so my name is Colton. I'm an epidemiologist with the Tennessee Department of Health. I work with the Public Health Systems Surveillance and Informatics Division. So first off, I want to say that I am not representing the state of Tennessee in doing this. This is my own personal opinions. So to give you a little background on myself, I graduated with my master's in public health and a concentration in epidemiology from the University of Memphis in 2018. I began working with the Metro Department of Health in Nashville on COVID response in early 2020. There I was a cluster investigator and I was also a lead on data quality. So kind of a nerd, but not real good public speaker. So if y'all want to keep an count, have at it. Open to feedback. So just I'm going to give a little background on public health, what it is, what epidemiology is, to kind of explain where we're coming from. So public health is a broader umbrella term for everything that we do. So it's really complex. There's a lot of strategic approaches to improving health outcomes. And really public health is grounded in primary prevention. And we do that through education, promotion, policy, and research. And that research arm is where epidemiology fits in. So we study the spread of disease, and that's really any diseases, not just infectious diseases like COVID. So that's chronic and syndromic diseases. I believe we also have a section for birth defects, and so we really look at a lot of information, you know, from a lot of different aspects of health. And so typically how we do that is we create experiments, and that is comparing this in terms of that when it comes to the public. We can't typically or ethically do a lot of experiments when it comes to adverse outcomes. So we use a system, what we call surveillance, where we take live data and we compare it to controls and people that match demographic information, things like that, where we can kind of set up an experiment without having to cause harm to people. So let me go a little bit over the history of COVID-19. So it was first discovered in the Hubei province in China in late 2019. So we initially called it the novel coronavirus. Coronavirus is a type of virus. It's really just kind of describes the shape. We eventually named it the virus. We named SARS-CoV-2 as a sibling to the original SARS that was discovered in 2002. Now that's the name of the virus. The name of the disease that it caused is coronavirus disease 2019, which is where COVID comes from. So the first infection that we had in the US was in late January 2020. And the first confirmed case in Alabama was in March of 2020. So I was actually working with the Tennessee Department of Health in the Waterborne and Zoonotic Division at the time in January. And we were monitoring the situation in China. And it was really interesting to watch what seemed like a viral pneumonia at the time. We didn't have much information. And to see that kind of explode across the globe in about 3 months, where things really seemed like they took a pretty gnarly turn for a lot of the world. I think we saw some of the biggest ones were in Italy and Korea at the beginning that were concerning and led to the first round of lockdowns here in the U.S. in March. So the current situation in Alabama, I kind of wanted to look at this. Now, I don't work for obviously for the Alabama Department of Health, so I pulled this from the Alabama Department of Health's website. They have a dashboard up, and I pulled this from their website. I guess probably middle of the week last week as I was preparing for this. And so this goes to show you just exactly what the situation looks like in terms of community spread. Every single county is seeing high levels of community spread, and that's defined as more than 100 cases per 100,000 people. And
Colton, this is one of the graphics that the state image actually doesn't pull up on this side.
does that, if I move my mouse, can you see it now? No.
There it goes.
Okay. Yeah, that's what I ran into last night. Thanks for the heads up.
Yeah. Sorry.
No. And so the percent positivity, so more than 1 in 10 people that are getting tested are turning up positive. Those are just indicators that there's a significant amount of disease going on in Alabama. And so here's a look at the epi curve. Can you see that? Did it lagging as well?
No, it's there.
Okay. So this is something that we noticed that was pretty concerning. So if you look, this is starting somewhere around March here of 2020, and then we have the surge in the middle of the summer, and then we have the surge around the end of the year, and now we're seeing this nearly vertical tail in the month of July and August here. And so we're seeing almost double the rate of spread as what we saw in say November, which is where things were pretty concerning. And just to kind of model that, here's a can you see this graph of hospitalizations in Alabama?
Yes.
So that is modeling the same surge as your epi curve. It lags a little bit behind. But like I said, I took this from the middle of maybe last week, so these numbers are likely higher now. And so we are preparing, I think, nationwide because due to these new surges. We're gearing up for probably the worst surge that we've seen so far. So not to be all doom and gloom, because we have vaccines, we know more about the virus now, so hopefully we can take some action as quickly as possible and hopefully see that surge start to turn back towards zero. So let's talk about variants, because I think that's probably what you've heard a lot about fueling this surge. So right now, there's been over 200 different variants identified, and that's basically just any kind of genetically unique specimen that they've tested. And so the CDC will classify those variants into one of three categories: a variant of interest, a variant of concern, or a variant of high consequence. And so that is from lowest to highest in terms of perceived danger. So a variant of interest is something that we want to monitor and study a little closer. A variant of concern is something that we may want to take action with. And a variant of high consequence is something that may change the ball game. And luckily, we haven't identified any variants of high consequence yet. Delta, I guess the big one that we're all talking about right now is a variant of concern. And to kind of explain that, it's become the most identified variant in the U.S. And so that's upwards of 80% of the sequence specimens in the U.S. right now are Delta. So that's concerning. one, because we have low rates of vaccines, and we don't know as much about Delta as we do the other variants, or earlier variants. And I think the other thing that's really concerning about Delta is how quickly it's taken up that portion of the specimens that we sequence. So we in America, we don't sequence that many specimens, but we can kind of extrapolate that and make predictions of the population as a whole. And seeing Delta, at the beginning of July, we were briefed about 5 to 10% of the cases that we were seeing were Delta, and now that it's over 80%, it just goes to show you how exactly how infectious this variant is, and why it is one of concern. It's also been shown to be slightly more virulent in children. Children have shown symptoms more often, have been hospitalized more often with the Delta variant. I can't speak too much on the numbers on that. We're not typically briefed on the difference in those children that are hospitalized versus adults that are hospitalized. We're typically just looking at overall hospitalization rates. Now that's not to say that number can't be found. I just, we've noticed an uptick, but I didn't get anything too specific on that. So now I want to talk a little bit about mRNA vaccines and how they work. So an mRNA strand is called messenger RNA. It's a single strand of DNA, and it contains cellular instructions that as soon as that message is received, it's meant to dissolve. So I kind of equate that to a Snapchat message, or maybe like a self-destruct message from an old spy movie. But it's inherently unstable. The point of it, of an mRNA strand, is for one cell to communicate with another, and then for it to disappear. You don't need all of these old messages laying around in your cells. So that's one of the difficulties that have kind of come up with using mRNA, and why it's taken so long to make these vaccines. So COVID-19 vaccines are the first mRNA vaccines, but there have been years and years and years of research put into mRNA therapy, research into these vaccines, and just finding ways to stabilize mRNA. And so the other difficulty that we've had with using mRNA to make vaccines is you're using a very small chunk of a longer series of messages to help that cell create a what we call a spike protein. And so that's the recipe. So identifying what we need to make the right recipe can take a little while, but luckily SARS in 2002, it pushed the need for these mRNA vaccines. It gave us a reason to develop vaccines quickly. And so with the work that we had done on the original SARS, identifying that recipe, it actually sped up the process for us to identify that recipe for SARS-CoV-2. And so I don't want to overreact, but I do think that mRNA vaccines could be what we might call the next modern medical miracle, because with the safety, efficacy, and speed of producing these vaccines, there's a lot to love. It's paved the way to make quicker vaccine development for what is sure to be other new emerging viral diseases in the next years to come. The other great thing about this is that now that we know how to identify that small mRNA chain to develop that vaccine, it's more easily modified. So we have seasonal flu, and we have new COVID variants. We're likely to have other new emerging viral diseases. And so being able to quickly develop a vaccine may protect us from some of those other diseases and variants. So I want to talk a little bit now about how the vaccines and variants interact. So what we do know right now is that coronaviruses mutate easily. SARS, for example, one of my favorite stories is SARS. Uh, what happened with SARS was we saw the situation develop in China. It started spreading, and then just like that, overnight, it started to disappear. And it wasn't from uh, extreme public health action. It was actually mutations that kind of imploded on itself. Unluckily for us, now COVID has kind of gone the opposite way and has shown to be a little more active with its mutations instead of committing viral suicide. Um, but so the mRNA vaccines have been shown to be effective against all of the previous variants, but the early reports have shown them to be slightly less effective against Delta. And for the Lambda variant that we're really starting to monitor now, we're not really sure. There's not enough data on it yet. So to kind of call back to how we study these things, one of the things that we need is a large amount of data to make clear decisions. And so when in the early periods of these viruses spreading, it's a little more difficult to make those clear-cut decisions. And so, I wrote here that it's around 83% effective is what we've seen among the mRNA vaccines against Delta. But over the last week or so, since I started to put this together, we've seen other reports come out that have quoted those as a little bit lower, a little bit slightly less effective, and some as low as 40%. Now, that is not to say that that the vaccine is useless, but that it's something that we need to continue to monitor. So with that being said, without enough vaccinations to stop the spread in our communities, we're leaving the door open for new emerging variants. And so I received this question, do you foresee having to develop a new vaccine to combat the Delta variant as well as future variants? We may not need to develop a new vaccine for the Delta variant per se, but I do see that as we continue to see hesitancy across the United States and really globally when it comes to vaccinating, we will end up seeing new variants that will need to have new vaccines developed, or even in the news this week from the CDC, we're starting to see that it may be beneficial against the Delta variant to maybe we need to talk about adding a third dose or a booster after so many months of your initial vaccination. So simply, yes, new vaccines are likely going to be needed. Now, as I mentioned earlier, I think that with these mRNA vaccines and how easily they are to alter, the new variants aren't necessarily something to burn the town down about. No reason to panic. But it is something that we would still encourage you to get vaccinated so that that's not something that we have to see in the future. So this is another question that I got from you guys, and I really like this question. I think it's probably got the most public health answer to it. If I had COVID, why should I get vaccinated? So if I had a previous COVID infection, why then should I get vaccinated now? Wouldn't I be immune? And the public health answer to that is we don't know. And so we love to say that we don't know, because that's more work for us. That's something that we can solve. That's a problem that we can solve. So the reason we don't know is that the immune system is overly complex, and basically there's two systems. You have your active antibodies, and then you have your memory cells. And while some people may have active antibodies for longer than others, it's impossible really to know what those memory cells know and the recipes for those spike proteins that those memory cells may store. We can't tell how long those are, But what we do know is that reinfection is possible with COVID. And so with that being said, we also know that vaccines are safer than getting a second COVID infection. So, if it turns out that the vaccines last 2 years and then you need a booster, great. If it means that they only last 6 months and you need a booster, I don't think that that's in raising your risk anymore than facing a second COVID infection, which I don't think anyone who has had COVID, I think, could agree that having it again was probably not something they want to put on their schedule.
So Colton, I want to piggyback on that question for a minute.
Okay.
So what is the guidance on if you had an active infection, how long to wait to be vaccinated?
So when it comes to making decisions like that, making guidance, we really look at risk, and we try to make conservative judgments on how to put a timeline on those things. So 90 days is what we've seen the minimum of someone who's had a COVID infection. That's the minimum that we've seen their antibodies last. So after 90 days is when we could think that, some people may have antibodies that wane. Again, we don't know that much about the memory cells and how long they may store that information that they need. But if you've had COVID previously, then we would ask that you wait the 90 days before you get your vaccine.
Okay. But that's following your doctor's guidance too, of course.
Of course, yeah. So with anything, and I think I'm probably going to touch on this again later, but
Okay.
with any vaccine or any medical procedure, if you have any reservations, and especially if you're recovering from COVID, you definitely want to talk to your doctor about making any of those decisions. Right, which I think that's a good segue, talking to your doctor about what's right for you, because we want to talk about side effects, short and long term. So there's a risk to every medical procedure, and that includes vaccines. So in an attempt to be transparent, the CDC and every vaccine manufacturers have listed the short-term side effects that they have observed through their clinical trials, and so you can check that out on CDC.gov, or you can check out Pfizer they have theirs listed on their website. Moderna has theirs listed on their website. Johnson & Johnson has theirs listed. So you can always go and look at and see what they have listed as possible side effects. So I want to touch on some of the more common, and when I say common, I just mean that they're not common, they're rare, but of all of the side effects, these are the ones that we see the most. So allergic reactions, myocarditis, pericarditis, and vasovagal responses. So those are things that we've associated statistically with the vaccine. And so these side effects have all been shown to occur within the 2 weeks of injection. So these are the short-term side effects. So the risk associated, the numbers that we've been seeing, only about 2.5 cases per million doses have an allergic reaction. And I think I received a question about, if you don't know if you're allergic to some of the ingredients listed in those vaccines, how can you know that you won't have an allergic reaction? And I guess the simple answer is you won't. And that's a reason to talk to your doctor if you have concerns about that. But it's also very low risk, 2.5 cases per million doses. That's pretty low. Another thing that's listed is myocarditis and pericarditis combined. We're seeing about 24 cases per million doses, and that's typically in younger men, and it resolves within 2 to 3 weeks of developing that condition. And then the vasovagal response, we don't have too much information because it resolves almost immediately. It really is just associated with the anxiety over the vaccine. There's a lot of noise. There's a lot of information swirling out there. There's a lot of pressure, both politically and socially, about whether or not to get the vaccine. So I think that has a lot to do with these vasovagal responses that people are seeing. I know that there was that one big story about the nurse in Chattanooga that got the vaccine on the news and passed out. And of course that was scary to watch that happen live, but she's on the news. She's anxious over the vaccine, a lot of noise. And so she kind of had an anxiety attack. And so with that being, we haven't been able to associate that vasovagal response causally with the vaccine, and not able to differentiate that from other vaccines. So let's talk about long-term effects, because I think this is probably the one that rings loudest for most people. So far, we have not been able to statistically associate any effects with these vaccines after 2 weeks. And historically speaking, we have not seen any long-term effects of any vaccines except for one, which is a side effect that occurred later in life among it was diabetes after immunization with the specific influenza vaccine in infants back in '98 is when they discovered that. So outside of immunizing infants, we have never seen any vaccine cause long-term effects, that happen down the line. I know that's something that we really hear a lot about is, I don't want to be a part of a class action lawsuit in 20 years. I don't want to, grow a third arm, or, whatever the concerns are in the future. Pragmatically, we really can't see a risk because the vaccine ingredients are applied in such small doses. They're digested by the body and typically expelled within a few days to a few weeks, which is why you see those side effects in the short term, but you're not accumulating like you would a typical drug with a vaccine. You're not accumulating those ingredients to last that long. We're introducing a small message to our cells to grow a spike protein so we can identify a virus, and then it is digested and is eliminated from the body. So I don't think I know we don't have 20 years worth of data on these vaccines because they were created within the last 12 months, but I don't think that means that we need to worry about the long term. I think we can look at other vaccines and historically see that there is little to no risk. So here's another question I got is in my opinion, out of the 3 vaccines on the market, which one has the least risk of side effects, or are they all about the same? So I haven't really touched on the J&J vaccine in this, mostly because it's probably going to be replaced as these new variants emerge. And it's a more traditional vaccine. So I think most people will have a little bit less reservations about them because it's not a new type of vaccine. But in terms of side effects, I think all 3 vaccines share a similar risk, which is very, very low. I think combined, we're seeing somewhere around 30-ish per million doses of a side effect. Now, when I'm talking about those side effects, I'm talking about these short-term side effects. There's other obviously more common side effects like the low-grade fever or the headaches that people are getting after the vaccine as their immune system kind of jump starts with that vaccine. But outside of those that are really common, these more rare ones are in the 30-ish cases per million, which is very rare. So I think another thing that people have reservations about is that we're lacking FDA approval, or they call these experimental vaccines. So I want to address that and kind of talk about that for a second, because these are some of the safest vaccines in terms of how closely we've monitored them. So we expect this FDA approval for Moderna or Pfizer, hopefully by the end of the month. It's hard to put a timeline on that because it's so nuanced. It's a very bureaucratic process. There's a lot of red tape, a lot of peer review to be done. But this should be a credit to us as a medical community because we do scrutinize these studies over safety. And to kind of put that into perspective, people have been complaining about the lack of clinical trials. I hear this, I won't take this experimental vaccine. It's right now currently under emergency use authorization, and you can't even apply for emergency use authorization until your phase 3 trials have been completed. And so that's a minimum of 3,000 participants. The phase 3 trials for Pfizer and Moderna were over 20 times larger in total than what we expect from a typical phase 3 trial. So Pfizer had 41,000 participants in their original phase 3 trial, and Moderna had 30,000 participants. So that's a lot of data. That's a lot of data for us to analyze and for us to see that we can move forward with the emergency use. So now, what small little hangups in the FDA approval are, that's something that has probably got, there's a lot of applications that people, paperwork, stuff like that's kind of hanging up the works. But globally, we have 4 billion doses of the vaccine that have been administered. So really, we don't have too much left to learn in terms of vaccine safety. With 4 billion doses, we can really look at efficacy, and we can really look at safety. Again, I'll call back to how epidemiology works, is that we create these experiments, and I put that in quotes, through surveillance. And so the larger amount of observations you have, the more quickly you can come to conclusions. And so right now, the general conclusion is that these vaccines are very safe. So in conclusion, the current rate of COVID infections in Alabama is about 1 in 1,000 people. And so the risk of an adverse event with the vaccine is estimated to be right around 30 per million doses. And so we also know the more people vaccinated, the more difficult it is for COVID to spread and mutate. And so vaccines are the safest and most effective way for you to protect yourself, your neighbors, and the children that you work with from the adverse effects of a COVID-19 infection. So with all of that being said, I think I pretty well covered the questions that were sent to me. Do you have any follow-up questions for me?
You answered it once. I want to know his opinion on, I've had COVID and they told me I couldn't get the vaccine for 90 days. Right. Is that what your thought is? Okay, I didn't know if it was just.
So,
Okay, sorry.
Allison just came in.
I want to get it, but they
has recently recovered.
Mm-hmm.
So she was asking about when to get her vaccine.
Like, when is the 90 days? Like, when does it
So
start?
when do you, is it 90, she had the monoclonal infusion.
Yes.
So does the 90 days start from her infection or from her recovery?
Yeah, that's a good question. And I think you ask any health department, they'll probably give you a different answer. Because it's kind of a rule of thumb. It's not really, that's not grounded so totally in, we know that your antibodies wane at 90 days. It's we know that it's possible that your antibodies could wane in 90 days. So that's why we want you to wait. If you waited, 100 days, does that put you in that window of getting sick? Probably not. But we, like I said, we take the conservative approach to making those types of decisions. So I would think that 90 days from your first positive test is when we would probably say is the right time to do that. But again, I think you can talk to your doctor about some of those more difficult decisions or getting in the weeds on some of those dates.
So you know that our agency, our board made a decision, and it was part with management recommendation because we do have so many young children. We have a lot of children with chronic health problems and disabilities that are enrolled in our early Head Start and Head Start programs to require mandates by the end of October. And hearing, we're having such a spike here now, so many positive cases right now, that in order to treat those employees fairly who can't get that vaccine, because we're requiring a mandated vaccine by the end of October. And I think what we will have to say is for those employees who have had it and can't make that they get just something from their doctor schedule, and because, you know.
Yeah, I think, yeah, that's those little pockets of dates that can kind of overlap and make things hairy for paperwork or,
Yeah, paperwork is scary.
Yeah. That's what, we, when I was working with Metro and doing cluster investigations, like trying to help these people get back to work while they were maybe in their infectious period, while they were talking to this person and this person needs to go, it gets really complicated. So I think you could probably work with your health department to get a release on things like that. I think that would probably be a good place to start, or even just have them go to their doctor and say that I'm 90 days within my last COVID infection. And my date for my first vaccine can be this date. I think that.
So what is the projected timeline for providing vaccinations for children under 12? Do you know?
Yeah, that's a really good question. And that's something that I think that's something else that we can wear as a badge, as we are very cautious when it comes to vaccines and long-term effects, because we do know that there is that one vaccine that had adverse effects down the road. So we want to make sure that we kind of inch that closer towards the kids. So I don't know that we have a really good timeline. That's going to be probably per manufacturer about how they approach that and how they want to push that. I wouldn't really expect to see anyone push for, infant vaccination, not anytime soon. But I think initially we were seeing 18 was the cutoff, and then they cut it back to 16, and now it's 12.
12. Yeah.
So I think we're probably going to see that push back to 10, 8, and so on until we can monitor that. Because we know pragmatically that adults respond well to vaccines, but when it comes to children, we want to tiptoe that a little slower. Which I think that goes to your point of wanting to get your staff vaccinated, is that you're dealing with children that can't get vaccinated. So it's important that we surround them with people that we know are protected, so that we can protect them, almost protecting the herd by doing your duty to protect those children.
Well, we did talk today about the importance of education, and part of what our concentration, and not just helping educate our own employees, but getting the message out to our parents that bring their children so that they can help us by getting vaccines for themselves and their children that are eligible to take it, older children. There is a lot of hesitancy among African Americans that are, point to this Tuskegee project and other things. And I think that sometimes plays on their fears culturally, and we're just hoping that we just want to continue to give them the confidence in their healthcare providers and all of you working the level you're working in, so that we can overcome some of these strange and bizarre rumors that are out there. And, and some of them you want to laugh, but what's not funny is the effect it's having on our communities. And that's
Right.
an unfortunate thing.
Yeah, I think in public health, we try to approach everything with a sense of social justice. I think that communication on our end is not always what it should be. I think it's difficult to attack those rumors head on, especially in a public capacity. I think that's something that we can improve.
And yeah, from the logical side, when you do a little history and you look at actually what happened in Tuskegee, it was that they were told they were given medicine that was going to help them be better, and they weren't. It wasn't that they were given medicine that was going to harm them. What they were given was the placebo, and they thought they were going to get better, from my understanding and my history of it. But, so I think it's just something we're going to have to respect culturally, and to really do. I'm proud of some of the things we've done, and Sarah has helped us do a lot of that in terms of having our employees tell their stories about what happened to them and why they got vaccinated afterwards, and why they want everyone else to. Because people can always go on Facebook and find that one case and that one person that had an adverse reaction to a vaccine, and that's what they want to talk about, not all the rest of us that have gotten it. And we'll line up for that booster as soon as we can get it. And so, I know it must be very frustrating for all of you looking at the science.
Yeah, and I think what's frustrating for us is we look at data, and it doesn't really have emotions. It doesn't pick a side. It just tells it how it is. And it's hard for us to kind of appeal to the emotional side of things without coming off as hyperbole or fear mongering, which I think is what we heard a lot of at the beginning, or overreacting. When I had to shut down construction sites because they had massive outbreaks, it was, I was the bad guy, and it was, the bad guy is that we have a virus that's going around, and it's dangerous to the community.
The president of the chairperson, I think the president of the that I was talking about, of the Alabama Hospital Association, who said day before yesterday on CNN, we were at a negative 11 beds in our ICU units right now, and had the largest number of cases reported in Alabama at 4,000 cases day before yesterday, which is a lot more than what your data was showing just last week.
Right. Yeah. Just last week, that was 2,000 cases a day. So you've doubled in 7 days. Yeah.
Yes.
That's very concerning.
She used the word, if we keep going like this. She said, I don't say this lightly. She said, it is going to be apocalyptic. She said, we don't know. And what she said was the scary piece, and I heard it today on a call with state DHR, the numbers coming in about the number of children who are going in and are having to be hospitalized, and the number of PEDS beds available for young children are not at the same numbers that we have for adults. And hearing all that today was just really,
it's scary.
It's very scary. And for people to I don't get it. I mean, it's like, well, what do you think is going to happen? Do you really think it's just going to go away? That to me is like, what are you waiting on? Yeah, I
And
mean,
especially knowing that you can have a secondary COVID infection, knowing that you can get it again, and it's not just once everyone gets it once, we're done, right? So it could continue to circulate and mutate but it's scary, but at the same time, we have a solution, and the solution is go
exactly
get
right.
vaccinated, and it's
That's
pretty,
what she said. We
Yeah.
have a solution. Yes. We need you to go take advantage of it, was basically what she said.
right.
Okay.
Yeah, and I'm sure you can walk outside outside your house and just yell, "I want a vaccine," and somebody will show up and give you one.
Well, it was interesting because we had a site here, we're in the mall complex here, Bel Air Mall Complex, which is,
Where Kaylin was working at Chick-fil-A
No, I don't, but
at the mall.
at the mall,
at the
right here
mall.
off Barefoot Boulevard, big mall. And they had a store that had closed down with a entrance that didn't have to go through the mall, but off the parking lot directly. Mobile County Health Department set up a testing and vaccine site, and the mall owners had them shut it down because they were afraid that people who were infected were coming there. And apparently it was just gonna go up into the air somehow. And so, there's enough stupid to go around, really. You just can't fix it. But we just so much appreciate you taking your time to talk to us today. We're data driven. That's the thing. See, all of us sitting in here, we have to do data all the time. And so we can probably relate more than most folks would when you talk about the data, because that drives our program decisions, that helps us know if we're achieving our goals. So,
We relate to
it's
that.
how we relate to that. It's how we function. And I'm hoping that because we preach this so much to our teachers and everybody else about the importance of collecting the information and looking at what it tells us, that it somehow will resonate. That's all we can hope.
Yeah, and so I mean, you can agree then that the data tells you what it says, right? It doesn't pick a side, and so it's hard when you report things like -11 beds to hear somebody dismiss that when we look at the data and we can make interpretations of what that means. Looking at that nearly vertical curve that Alabama has, and the hospitalizations, and then to kind of dismiss that as, I don't understand it, maybe, I don't know what the hitch would be with that, because that's what we do, right? But
well, the CNN reporter asked the lady, she said, "What does that mean?" And the doctor said, "Lots of really bad things." And so she proceeded to tell them. So it's like, what does that mean? Well, it means really bad stuff. If you are in a car wreck and you may need, intensive care, you may be sitting in an emergency room without those specialized equipment and everything you need. You may not be able to go, into kind of the intensive care.
We haven't even had ambulances available
Right.
because Brian just said the other day
There are
that
people parked in them.
the ambulances are sitting outside of the ER for like 4 hours, waiting to send that patient inside because there's an 8-hour wait in the ER.
yeah, that's tough to hear, and it's tough to think about the people who are in there working and trying to get these people taken care of, and knowing that as soon as this one is stabilized, they have to go start on the next one who might have degraded in the last 4 hours. Yeah, that's scary. But like I said, I think I don't lose too much sleep over it, because I know that we have a solution. But we have to come up with a way to communicate how easy and safe and effective that solution really is. And so I hope that this today, at least reaches somebody.
Well, I'm going to share the recording with our staff. So if they have additional questions, they'll send them to me and I can get them to you.
Yes, please do. And my email was in the Zoom meeting. So if anybody else has anything that they want to ask me directly, feel free. I have no issues with that. I don't know if I'll get to it because that's my personal email and it's usually full with, ads, but
All right.
I'll do my
Thank
best.
you so much. I appreciate it.